Hi, everyone. Good morning, good afternoon, and good evening. So this is one of the few times that actually we have audiences across all different time zones joining us for this webinar. So welcome to everyone. My name is YY Teo. I'm the Dean for the Salisbury Hock School of Public Health at the National University of Singapore. It's really our privilege to be hosting the second APRU session on academic collaborations during a crisis. I'm particularly excited by this theme of academic government partnerships because we could see that around the world, just to check, I received a message that there's no sound. Alex, could you show me an indication if you can hear me? Yep, thanks everyone. Great. So I'll continue. So I think worldwide, we have seen countries and cities that have performed well during this pandemic crisis. And this have been characterized by the strong partnership that exists between scientists, be it infectious disease experts, public health practitioners, epidemiologists, this partnership between these people and the policymakers, and actually evidence-based policies and programs trying to design culturally appropriate measures to protect the people against infection, even to the most efficient way of managing any infected people, avoiding community transmission, or even to try and identify or calibrate solutions for handling incoming travelers as borders start to relax their measures. I think the science of the SARS-CoV-2 coronavirus has evolved considerably since the first official case that was reported, I think on the 31st of December last year. Now we know quite a bit about asymptomatic infection and transmission. We know a bit about the risk of infecting livestock such as the minks, which in turn reinfect humans with potentially mutated strains of the coronavirus, or even the possibility of being reinfected after one has been experienced a first episode of infection. Scientists and academics actually remain very much at the front line to create and generate insights and knowledge. And the question really is, especially to the audience today, how are this information and knowledge created by scientists like you and me, used by policymakers worldwide, and whether local scientists are actually working hand in hand with their own governments to make sure that the knowledge is transformed to powerful, effective policies. After all, I think we keep hearing that there is no one-size-fits-all approach to handling the COVID-19 pandemic. While the public health measures, the approaches that are recommended to contain the outbreak are the same from the World Health Organization to different countries, the implementation, the execution of these approaches needs to be contextualized to different countries such that it can be appreciated by the local people in your own country. What works in East Asia may not be relevant in Northern America. Mandatory measures may be accepted in some societies, but will be rejected, causing great unhappiness or even protest in other societies. Local scientists and academics, especially social and behavioral scientists, play an important role to inform their government, their local governments, on culturally appropriate measures. APRU, as the Association for Pacific Rim Universities, stands very much at the forefront to embrace and champion this principle of academic governmental partnerships, especially during a crisis. And after all, I solely believe that the role of a university is not just in knowledge creation and knowledge transfer, but also in knowledge implementation. So with this, I would like to hand over to the Secretary General of APRU, Dr. Christopher Tremawant, for his introduction and speech. Over to you, Chris.
Oh, well, greetings, everyone, and many thanks to Dean YY Teo for his wonderful overview. It sets out very well the whole point of this APRU Crisis Management webinar. As he said, I'm Secretary General of APRU, located in the International Secretariat based in Hong Kong. And I'm also a political scientist with a strong interest in academic participation and public policy. So this is a very important topic for me as well. This webinar is hosted and led by the National University of Singapore, Saw Swee Hock School of Public Health. And this is the second in a series of 4 webinars. APRU is privileged to partner with its 4 member universities in producing this series, 4 of them. NUS, Peking University, Sydney University, and UCLA. They are, of course, all renowned for their capability in public health and have been very active in public policy nationally and internationally during this pandemic. As has been already observed, the knowledge created by universities through their academic research is used to inform policy and government level decisions. At the same time, the practical experience of leaders and decision makers can provide insights for researchers. The relationship between academic departments of public health and government has been crucial in many countries during the COVID-19 crisis and has been managed in different ways depending on the local context and the way the pandemic has developed. This webinar will discuss similarities and differences in approach, the various experiences advising policymakers during COVID-19, peculiarities of this unprecedented crisis, and lessons learned that could inform academic-government partnerships on future occasions, including but not exclusively in emergency situations. So with that, let me just say a few words about APRU. For these reasons that I've given, we actively support the development of the APRU Global Health Crisis Management Program in direct response to this pandemic. And APRU is an association of Pacific Rim universities, is a network of 56 leading research universities. And you can see on the slide that we are located around the Pacific Rim. And there is the list of members as well. So we share the geophysical features of the Ring of Fire and all the issues related there. And we have areas of expertise related to that across a wide range of subjects within our members. So next, I would just like to say that we have had a very focused response to the COVID-19 crisis. We've ensured the sharing of information and experience across the Asia-Pacific region to assist colleagues in widely differing circumstances. So you see there, we started a website to assemble all this learning, and we called it APRU Plus. So like everyone else, we've undertaken many activities virtually in a wide range of programs. With respect to the pandemic, we've hosted more than 10 COVID-focused webinars, converted virtual events, including our annual multi-hazards disaster risk reduction summer school, and hosted 2 large-scale conferences online. First on global health and secondly on sustainable cities and landscapes. So this somewhat paradoxically has extended their scope and reach to many new participants. And we've also started an APRU virtual student exchange program. The APRU Global Health Crisis Management Program, which is running this webinar, was initiated by the Peking University School of Public Health, a leading school obviously in China. The program's 4 core members are aiming to build on their experience of the different ways the pandemic has affected their cities and countries. So please explore this website, www.apruplus.org, if you want to know some of the activities and responses from experts and researchers in the region. So I wish to thank again Professor Wai Teo, the Dean of Saw Swee Hock School of Public Health, and Ms. Eliza Kawati from the Leadership Institute for Global Health Transformation, also at the same school at NUS, for developing and bringing this webinar together. And may I also thank NUS Associate Vice President for Global Relations, Professor Victor Shim, and all the expert speakers that are contributing today from our partner universities. I'm confident and sure that this will be a valuable opportunity for all of us to extend our knowledge of this important topic. Thank you so much.
Thank you very much, Chris. So I would like to hand over uh, next to Professor Victor Shim, who is the Associate Vice President for Global Relationship at the National University of Singapore. Victor, over to you for your welcome address, please.
Thanks very much, YY. Well, a very good morning to our friends in Singapore and China, to our friends in Australia, good afternoon, and good evening to our friends in the United States, and to anyone else who's listening in, but not in one of the countries that I've stated or regions that I've stated, good day to you. As YY has mentioned, I'm Victor Shim, and I serve as Associate Vice President for Global Relations at the National University of Singapore. Together with my colleagues in our Global Relations Office, we promote and facilitate student mobility programs and manage university-level alliances and networks. Every student we send out and receive, and every study abroad experience we facilitate, is a testament to the importance of building partnerships and collaborations among institutions around the world. It's therefore a pleasure for me to say a few words of welcome before we commence today's webinar on this topic of academic-governmental partnership in public health that's hosted, as you've heard, by the NUS Saw Swee Hock School of Public Health. Now, because NUS is a member of a number of university alliances, we've been able to see how universities worldwide come up with innovative forms of partnership to overcome the challenges precipitated by the current pandemic. For instance, the Association of Pacific Rim Universities, or APRU for short, member universities got together very quickly to launch a virtual exchange program that Chris mentioned for students affected by global travel restrictions. Now, this was done by offering academic and co-curricular activities online to enable students to continue engagement and interaction as much as practically possible. This one-of-a-kind initiative actually garnered great positive response internationally and was shortlisted as a finalist in the Digital Education category of Science Breakthroughs of the Year at the 2020 Falling Walls Conference. Now, in this area of public health and crisis management, partnerships are also key in achieving better outcomes. Cooperation among experts in public health around the globe is indispensable in winning the fight against COVID-19. And in these challenging times, the power of leveraging on networks and partnerships to rally like-minded people together and therefore multiply their outputs really cannot be underestimated. It's become patently evident that strong partnerships, international collaboration, and sharing of information without borders are critical in addressing common global challenges. In parallel, strong ties between academia and government in the sphere of public health are really invaluable in helping identify priorities, maximizing efficient use of resources, and strengthening national and global responses to public health challenges. The presence of eminent experts in today's panel gives me full confidence that this session will yield highly beneficial insights and generate fruitful interactions. So thank you for taking time to participate. And now back to you, please, YY.
Thank you very much, Victor. So today it's a pleasure to introduce 4 distinguished academics and speakers who will share their professional experience of how they have actually worked with their local governments in handling and containing the outbreak. I will just have a very quick introduction of the format. Each of the 4 speakers will take turns to present what they have been doing with their policymakers in their respective countries. We will not take any questions and answers immediately after each presentation, but I do strongly encourage the audience to actually make use of the Q&A chat box in Zoom to leave your messages even while you're listening to a presentation. We will curate all the questions that have been posted at the end of all 4 presentations. That's where we will have a moderated question and answer. So without further ado, I would like to actually introduce the first speaker for today, Dr. Yang Huan from the Department of Global Health at the School of Public Health at Peking University. She will be talking about the multilateral collaborations in fighting against COVID-19, some of the experiences from China. So over to you, Dr. Huang.
Thank you, Dr. YY. Hello, everyone. So it's my great honor to be here to introduce how we Chinese public health workers have been working with the national government and also with the world from different countries to fight against COVID-19. So today, the experience is not only from myself, but also from our faculties and also from our friends around the country. So actually today I'm going to introduce from the following four contents. The first one, I would like to fastly go through the global epidemic. Of course, I'm sure you will all agree with me that it's now still a very big pandemic that calls for global interactions. And this figure actually shows how different countries are suffering with the COVID-19. The reason I'm showing this is to illustrate that every country might face different situations. What we have done in China might not be suitable for other countries, but we have proven to be successful. What we have done is suitable for China, and I'm very happy to share what I have done till now. And if there is something that is in common, it's so great to share and exchange your ideas. So back to the response in China. This is actually a very famous picture that was taken in February 2020. At that time, COVID-19 was spotted 1 month after Wuhan was first spotted, the COVID-19. And WHO have invited different experts from different countries to visit Beijing, Guangdong, Sichuan, Hubei provinces to see how China have acted after we spotted within 1 or 2 months. So this is actually what Dr. Bruce have summarized. We can look at this picture, how China have responded soon after we find that COVID-19. So we remember when we first found that it is an unknown disease with no idea what is it, how it can be transmitted, and how serious it is. So what we have done at the very beginning, I think, was also we said is very a classical public health workers perspective. So how to try to stop the transmission, how to act collaboratively with different institutions and different sectors is what we think is not only an experience for COVID-19 response, but also for how public health workers could contribute in the future epidemic for other infectious diseases. So from our experiences, we can summarize what we have done in the following 8 aspects. First is scientific-driven response, which is very important, and how we public health workers have been participant a lot. The second one is core traditional public health measures, which we think is a key that we can stop the transmission at the very beginning without any understanding of the disease. And the third is the critical bottleneck positioning and settlement, community mobilization, transparent public communication, leadership and coordination, strategic R&D, and of course, international collaboration. So today I'm going to elaborate each a bit and to show how we could work actually collaboratively and how we can change the history. So first about the science-driven response. So this is what we have done at the very beginning when we first found COVID-19 in Wuhan. At that time, we know it's an infectious disease. And in order to make sure that it can be stopped at the certain region, we try to locate each area based on the situation at that time. So at that time, China was classified into low-risk areas, middle-risk areas, and high-risk areas based on different criteria. And I think this criteria is also being shared around the world and being used in many countries. So due to different aspects of the areas, we have tried different ways. For example, for the high-risk areas in Wuhan, we have stopped local transmission, prevent exportation, and implement strict measures. And because of that, those strict measures at the very beginning, it is why we could stop it within 2 or 3 months and didn't let it go spread around the world. And So this is another example of how we have used our scientific-driven ideas or knowledge to improve our understanding and help the country to kill or to deal with the disease. So you can see there are two different colors, and all these numbers are the timelines. So at the very beginning, at June the 15th, we can see the first version of diagnostic and treatment protocols and prevention and control protocols was both brought out based on almost only about less than half months of the understanding of the new disease. And then due to all the interactions between public health workers and clinicians, they have fastly changed the protocols based on the emerging or the new ideas from all these patients. So you can see within just maybe 3 or 4 days or 8 days at the very beginning, we changed the protocols day by day based on our newest knowledge and shared with the country around different hospitals. So the physicians and the clinicians could actually do more when they know the disease better. And you can see that within 2 months, we have almost 6 or 7 versions changed. And due to all these understanding of the new scientific ideas about the disease transmitting, I think it really helped us to not only let the physicians know how to protect themselves, but also to let the people around China know how to protect themselves and the people they loved. So the second is the core traditional public health measures. At the very beginning, when no one knows what the disease is, we still believe that the traditional public health measures are actually the key, and it has been proven years by years that it's still working very well. So we have taken the following 5 actions. First is, of course, universal population measures, case isolation management, close contact quarantine, suspension of public gatherings, and movement restrictions. I'm sure all of these sounds very familiar to you all because many countries are doing the same. So what I want to elaborate here is that the basic knowledge that we have gained from our public health teachers and faculties is still working and still working well. And it's something that we have to stick on when we have scouting some unknown diseases. And also we have summarized several key experiences, such as for defenses, for such as early detection, early reporting, early isolation, and early treatment. All these are very fundamental public health ideas. And the other one is by the people, for the people, which we think is the key that we can fight against COVID-19. So at the very beginning of the COVID-19, all the people in China have been mobilized and have been trying to contribute to this fight. So there's community engagement, community health education, and community hygiene and disinfection that have been implemented by health workers and also by all the people in this community that work together. And of course, coordination, cooperation, and communication is still the key, because we know that with all this coordination, we can make sure the resources can be allocated to the person that really need it. The logistic support is especially important. And the public understanding and infodemic response is also very important to make sure that the people in China could understand why we're taking all these actions and why they should try to correspond to all these actions. And here are some containment strategies that I don't want to say too much today, because I'm sure we all agree with them now that it is very important, as for example, to keep social distance or to have social mobilization, etc. So at the very beginning, we have taken some critical bottleneck positioning and settlement, especially in Hubei, Wuhan. And at that time, nationwide, 1.4 billion people have underwent 10 days of at-home isolation. And in Hubei, we can see that over 50,000 hospital beds were opened for COVID-19 patients, including 3 new hospitals and 16 temporary model hospitals. And all of these cannot be done without any collaboration, not only from the health workers, but also from constructors and also from many, many different areas, collaborations. And what we're very moved was that more than 40,000 healthcare workers were deployed to Hubei at the very beginning to make sure that all the cases can be treated. And because of all of these hard works, I think the national, the people are all thankful to all these healthcare workers. And you all know that now China have been opened up and we can go to different sightseeings and restaurants, everything. And for China, for this whole year, most of the sightseeing are free for healthcare workers and their families to show our expectations and to show the thanks to the health workers. So I think these are the very good examples of how people could work together to be moved by each other and how we could combat on this unknown disease at the very beginning. And also we have community mobilization such as contact management. I think this is also being used in many other countries. And due to this quarantine, either at home or at the designated places, and because of all this contact management by professionals from the communities, I think we have tried to stop the transmission faster than we have expected. And also we have done a lot of health educations for general publics and for occupational exposures. And all these have been done by public health workers working together with clinicians and many other health workers. So we can see that during this whole process, our public health faculties and researchers have not only done research itself, but also have provided a lot of social works that can really make people understand the importance of keeping all these public health actions alive. And of course, we think transparent public information is very, very important, especially from the very beginning. At first, maybe people might not understand the importance or the seriousness of this disease, but with every day, because we uploaded the newest number of confirmed cases and suspected cases. So people started to understand how seriously at the beginning, and people started to understand that it is real number because it can change, see it changing in different cities, and you can see that it's the really situation in that place. So due to all this transparent public information, people started to trust the information, to act according to the information. And this is super important because it will guide us and guide the people to actually behave and to take certain actions based on each city's different situations. And leadership, firm political solution of government is, of course, we all agree is very important. To cure or to deal with COVID-19 is not the work that can be only done by health workers or public health workers. It needs social mobilization, it needs collaborations with different sectors, and that requires a political commitment that call for all people to work together. And we are happy to see that around the world, all people are realizing the importance of combating COVID-19 together. And many people have been understanding of what we have done and try to work together to make sure that it can be back to normal. And here are some examples that we have done within 1 month that have such as canceling mass gathering and extending spring festival holidays. I think this is also some of the experiences we could share now, because we're now unfortunately moving to the next round of holidays. And at the very beginning of 2020, at that time was Spring Festival, only almost 5 days after we had the Spring Festivals, and we stopped, canceled the mass gathering before it. And many people have to cancel their airplane tickets or their trips in a very short time. But because of all these sacrifices of gathering with their families, I think it really helped us from putting all this virus going spread around the country. And we're not sure what will happen this year during the Spring Festival, but people are still very careful about mass moving, and we're also taking many of the protection measures because of all those health educations along the way. And another one is the strategic research and development, the R&D. I'm sure we all agree that drug, vaccine, and diagnostic is very important. And this sound might not be much related to public health, but we have to say that many of our public health faculties have been involved during the time. So here are some examples of how we've done it and how multilateral collaborations can actually spread up the speed. So you can see, I'm sorry about all these small words, but you can see all these green boxes illustrate how the government have been taking actions for disease transmission. And all those brown boxes are actually the governmental policies for improving R&D. So you can see just within 1 month, a lot of governmental actions have been taken in order to make sure that the R&D can be speed up and to make sure that we have more diagnostics at the very beginning to make sure that we can spot all the diseases or the cases that we need to find. And at that time, at the very beginning, we start the whole government actions. So this whole government action is not only for R&D, but also for, we can see it for many other different actions. But I just take this R&D as example to show that how we can work, the scholars and all those government officials could work together. So this whole government action was actually started in the very beginning of January, and there are 2 groups that was set up. The first one is the Scientific and Technology Research Group, which was led by the Ministry of Science and Technology and has included representatives of 12 government departments. And at the same time, a scientific advisory group, a SAG, was formed, including 14 academics. And all these are experts that have a very good knowledge on infectious diseases and research and public health. So the SAG and STR group, they work together to discuss how to form a leadership structure to ensure the R&D coordination and ability for rapid decision-making. And this kind of whole government actions that work between the government and the scientists have been seen in so many different aspects while during with COVID-19. And I think because of the trust to all these scientifics, especially the trust for public health workers, that is the reason why we could make sure that many of our public health actions could be informed and could be taken in action nationwide. And because of all this leadership, we have established a priority of different R&D themes to make sure that it could include all the things that we needed. And also we have a fast track review process, such as a parallel coordination mechanisms and jointly submission and review mechanisms. So all these coordination mechanisms, the only reason is to make sure that we don't waste any management times. So the government will work together with the scientists to make sure that the scientists don't have to wait a certain time for the government to come back to review all your research. They work together to make sure that the time can be limited to the most short time. And this can also be seen in many other places to see that how we try to make sure that administration will not be a trouble or an obstacle when we try to moving faster than ever. And also there's diverse funding mechanisms. And these funding mechanisms, of course, is not only for basic research, but also for many researches related to public health. And many of our colleagues in Peking University School of Public Health have been holding some of these fundings to make sure that we understand this transmission and to understand how we could actually combat COVID-19 from a public health perspective. So this funding mechanism, including central government, there are assigned, funded, and also there are research topics that were announced for open competition by National Scientific Foundation. So due to this assigned funding and open competition, we can make sure that not only the top scientists could be involved in this period, but also people with different background, if they're interested, they can all join in to compete and to make sure that we can include all the people that are with some knowledge that we really need. And also beside the central government, there are provincial government that also could help us with all these works. And you can see that international collaboration is also very important during the time. And we have mentioned that China's contribution to global innovation and access have been proven, and I'm sure have been agreed by the world, that collaboration around the world is very important, not only in R&D, but also in many other aspects. So about the prevention in China, I'm sure after this, we have seen that many actions have been taken while the pandemic had been mostly stopped in China. And all of this preparation have provided us a way to help us to actually deal with all these diseases. And also, we believe that global collaboration is super important. China has provided multilateral collaborations on COVID-19 in many different areas, not only bilateral, but also multilateral collaborations. And we have to say that from this figure, you can see the network of international collaboration relationships between COVID-19 periods have been shown that different countries have been working more closely after COVID-19. So to end our speech today, we have to say that let's collaborate and let's work together to combat COVID-19 in a short time. Thank you very much.
Thank you very much, Dr. Huang. And I think that's a very impressive and systematic framework of crisis management that you have outlined. And we see that it spans very upfront communication, very upfront understanding of the outbreak situation, transparent communication, clear leadership and political will to take tough decisions, including canceling plans for spring festivals. Yes. And that is actually the largest social event in the Chinese calendar. Yes, and also the way that knowledge from basic scientists to applied scientists, including virologists, vaccine experts, and epidemiologists, have contributed to the response that we have heard you outline for China. So thank you again. And with that, I would like to invite the next speaker, Professor Natasha Nasser from the Faculty of Medicine and Health over at the University of Sydney. And Professor Nasser will be sharing with us some of the experiences that she has with the New South Wales Ministry of Health Public Response Team. So over to you, Professor Nasser.
Thanks, YY. You can hear me? Yes. Okay, great. So thank you for the opportunity to speak to you today and for the invitation. And I guess I also have to thank the University of Sydney and the School of Public Health for inviting me to talk about my experience working with the Ministry of Health and the operations team. So this is a much more hands-on experience. I'm just going to take you through some of the work that we've been involved in. So just as a bit of a brief background, just on the right is just a map of Australia. So Sydney is based in New South Wales. We're about a third of the country's population and the most populous state. And I'm an epidemiologist. I've been working since early 2000s. I'm an academic researcher, mostly working in maternal and child health research. And I've done lots of work using large administrative data and analysis, looking at the epidemiology of health, risk factors for disease and health services, and mostly based at the university throughout my career. But in the early parts of the year, like everyone, I guess we watched the pandemic, and as we watched the pandemic emerge, I think like everyone else was sort of glued to the news, and just during these unprecedented times as the WHO declared the coronavirus pandemic, as new border controls and restrictions were introduced, and really feeling like wanting to be, contribute and not knowing what we could do. And then about mid-March, the New South Wales Ministry of Health actually put a call out to the University of Sydney and the School of Public Health in particular, and asking for staff and students who wanted to work and contribute as part of their COVID-19 rapid response team. And they were looking for all sorts of people to be. So I applied for one of these positions and was assigned to work as part of the operations team. Now, for me, I didn't quite know what the operations team was, but on the 23rd of March, I reported to the State Emergency Operations Centre. Now, the State Emergency Operations Centre, or the SEOC, was basically an initiative that was formed by experts from across the New South Wales government agencies, and it was to lead a state's coordinated emergency response to the evolving COVID-19 situation. It's actually managed by New South Wales Police, and it was essentially to control and coordinate the emergency operation and plan and allocate resources and provide information to the public. And it was a coordinated effort across multiple government agencies, including police, ambulance, health, education, transport, and emergency services. Now, before I tell you a little bit about what I did in the operations team, I thought I'd just give you a brief overview of the Emergency Operations Centre, and just to tell you a little bit that this New South Wales health response was essentially divided into two parts. There was the Public Health Emergency Response Centre, which is highlighted in blue on this slide, and the State Health Emergency Centre that was, it's highlighted in peach on the right-hand side. And essentially what the Public Health Emergency Operations Centre was responsible for was really to coordinate the case finding, the contact tracing, the outbreak control, communications and other preventative actions across the state. And then on the right-hand side, the State Health Emergency Operations Centre was really looking at managing and overseeing clinical operations in New South Wales hospitals and health facilities to support the healthcare workforce and to establish COVID-19 testing sites and coordinate the supply of personal protective equipment. Now, focusing more closely on the Public Health Emergency Operations Response Branch, or the PHRB, which was the blue shaded figure on the previous slide, the Public Health Response Team was headed up by Jeremy McNulty, our Deputy Controller, and essentially what it was made up of a vast variety of experts looking at surveillance and epidemiology, so really trying to support the intelligence and data gathering and data collection of COVID cases across the state. There was the operations team, which I'll tell you a bit more about. There was policy and health procedures team. So they were looking at sort of implementing the different public health orders, the testing regimes, the different fact sheets, and developing the reports, daily reports back to the state. There was a pandemic response coordination team who coordinated the logistics and sending of messages to cases and close contacts, and managing personal protective equipment and rostering. And of course, there was media and communications, which really was an important facet in maintaining communication to the public with daily updates from the Premier, from the health sector, and across the board. So focusing more closely on the operations team, where I was assigned to work, the operations team was located within this PHRB, the Public Health Emergency Response Branch, and it was essentially established to provide the team within the public health to provide advice, reporting and data analytics on the epidemiology and clinical aspects of the pandemic. And it was involved for outbreak investigation, for managing high-risk settings such as aged care facilities, schools and workplaces, managing pathology testing, providing reports to the media and to social media and other communication settings. We were responding to ministerial and providing ministerial updates every day. And we also convened expert panels where it was required for further investigation. We also managed the contact tracing of close contacts from clusters, and we liaised with a wide variety of stakeholders from New South Wales Health, the public health units, emergency operations and other government agencies. Essentially for the operations team, there were 2 shifts that worked every day, so a morning and an afternoon shift. There was a daily briefing where there was an update given about the latest events that occurred every day, and that happened twice a day. So each of the 2 shifts working were across each of the issues that were emerging each day. We had a web-based information sharing tool that we used, an online system called Trello. And there was an operations email account with over 200 emails per day that was basically filtering all of the different information and requests that were coming in. So for part of the operations team, this was actually led by an infectious disease epidemiologist named Jenny Musto, and it was supported by 2 team leaders and 8 staff per shift. For each shift, there were 2 teams that worked, one consisting of about 4 staff that helped manage clusters and outbreaks. And then there was a second team, the rapid operations team, which managed emails and inquiries, developed protocols, the cases arising out of hotel quarantine, which is another system and management of cases coming from overseas, and also looked after escalations and miscellaneous requests. And so the staff that basically comprised our operation teams were sourced from various organisations. So not only from the New South Wales Ministry of Health, but also from universities, research institutes, and public health trainees and biostatistics. And we had a mix of skills from medical and nursing to epidemiology and public health research, as well as policy and planning. Now, before I go into details and what the operations team, I thought I would just explain to you a little bit about the context of the public health system in New South Wales, because this really helps underscore the results of and the management of our COVID-19 response. There are 17 public health units across New South Wales shown in the maps below. And the right map shows the rural and regional areas of New South Wales, and the left map shows the rural and regional areas, while the right map is sort of a focused view of the metropolitan areas of New South Wales in Sydney, and that comprises about 2/3 of the population. So these public health units pretty much operate independently, and they've been operating over the last 20, 30 years, looking at public health management, communicable disease control, and infectious disease and rolling out infectious disease programs and services for people within each of residents in each of their areas. So during COVID, they were already well-resourced and experienced to manage case control and close contacts for cases that emerged in each of their areas. And they took responsibility for managing their cases in their local area and doing the contact tracing of the immediate contacts. But where the operations team came in is for COVID cases where the public health units. Oh, before I do that, I'll just tell you about what they did in terms of the management of the COVID cases in the public health units. They're basically responsible for notifying a case of their positive status, and they conducted a detailed case interview to identify symptoms. They identified the infectious period for the last 48 hours, and then an incubation period of the last 14 days, and reviewed the movements of each of these cases in that 2-week period. In this time, they also identified close and casual contacts and were also responsible for ensuring the isolation and home quarantine of cases and their close contacts for 14 days. And lastly, they recorded this information in NSIM, which is the Notifiable Conditions Information Management System, which was the single source of truth across the state in terms of entering details of all cases and people tested across New South Wales. And in terms of their contact tracing, their interview of the cases, they were basically looking at interactions of cases with different household members, with external people, during their day-to-day workplace or school activities, and across different transport and industries. So where the operations team really came in was that basically we were responsible for those for contacting people where there had been a close contact or they'd been diagnosed with COVID-19 for cases that arose in public areas or high-risk settings. We're also responsible for managing cases that occurred in clusters. And in terms of these high-risk settings, these included aged care facilities, schools and early childcare centres, healthcare settings, restaurants and hospitality, workplaces and group homes. And essentially, for these confirmed cases, what we did was what the involvement of the operations team really started off with was a teleconference with the public health unit and other key stakeholders in terms of doing a proper risk assessment and assigning the roles and responsibilities. And from there, the public health units would go back to their cases to identify the list of close contacts and then send these to the operations team, who would then take over the management and organise text to these contacts in terms of where they needed to stop and stay, the drafting and review of close and casual contact letters, the key risk assessment outcomes, and coordinating calls by the contact tracing team and organising the contact tracing team to make calls to the close contacts. We're also responsible for the subsequent follow-up of cases, the case summaries and reports. So during the COVID-19 pandemic, the close contact tracing team also played a key role in the management of cases and contacting people who were in close contact with people who'd been diagnosed with COVID-19. So they basically provided public health response, conducted risk assessments, and escalated concerns for those who didn't follow isolation. They entered data into the NCIMS database, and then also sent this information back to the operations team and the public health unit for review. The contact tracing team was a large resource in itself, with over 150 people working each day and making over 1,300 calls. And it included a diverse range of people, including the Australian Defence personnel, Qantas workers, and actually the School of Public Health, Masters of Public Health students were also involved in working as part of these teams. So this is just a visual, I thought I'd just show you a couple of visuals that we used as part of the operations team in terms of our cluster management and our case and close contact control. And this is basically a whiteboard of the different links that we sort of drew up as the cases emerged as part of different clusters. And it's purposely blurred to de-identify the cases. And you can see that the green lines sort of represent the spread. So the red lines indicate the initial sort of spread in one center, and then the green lines and the links sort of the subsequent spread of cases in various different situations. And as part of our work, we were responsible for upstream investigations to identify potential sources for cases and where they were infected. And then downstream investigation to identify transmission to people infected and links to the case where the close contacts may have come into contact with. This is another visual that we used as part of our work. And what we did was we created these epicurves, sort of plotting the number of cases each day and over time to sort of look at the emergence of the outbreak over time. Oops. Excuse me, sorry. And so we also used various sources of diagnostic information to confirm our case diagnosis. And essentially what this did was help us to sort of establish not only case diagnosis, but the timing of infection. So PCR testing is essentially taken from a respiratory swab of people. And we were sort of looking at CT values to sort of give us an indication of the infectivity of people, and the levels basically indicated whether someone was had strong positive reaction or a weak positive or an indeterminate person. Antibody testing, which was collected through serology and bloods, we're looks for the presence of antibodies, and this sort of gave us an idea about the history of the disease. And usually these antibodies developed post-infection, and this is just a graph or a figure that shows the different antibodies and the timing of when they developed. And across the x-axis, we can see that some of those antibodies develop post-transmission of cases, post-infection, and usually from about day 14, particularly IgG. Now, I'm not going to go into too much detail about this, but we also, about the other testings, but we also used whole genome sequencing, which was also a really effective and powerful tool that could help us understand the transmission dynamics in outbreaks and to help inform the public health control. So this figure basically shows the various sequences of the virus across different countries, and the different colors sort of indicate the different sequences that were identified from different countries. And then what we did was sort of basically use that to identify clusters and the source of transmission. We also used other forms of review by diagnostic expert panels for indeterminate cases, and then sewerage surveillance, which is a new program looking at testing sewerage for fragments of COVID-19. So to give you an overview of an investigation, I thought I'd just go over one of the links, one of these cases that we basically used, one of the clusters and the different strategies we used to identify the outbreak and the links between cases in this cluster. So the initial outbreak was caused by a Victorian freight worker. So a Victorian from a different state that was actually in Victoria, there was a large outbreak going on, whereas in New South Wales, there were very little cases. And what had happened was this Victorian person had travelled to Sydney for work and then passed the virus to a number of colleagues during their visit to the Sydney office. The group then went to a dinner party at the Crossroads Hotel on the night of the 3rd of July. This particular patient 0 was unaware he was carrying the virus, but from there an additional 34 cases were identified and linked to this venue. We used genome sequencing to actually confirm the COVID strain and to identify that the strain was actually one from Victoria and similar to one that was being spread in Melbourne. From there, new COVID infections were linked to the cluster at the Crossroads Hotel and identified a number of other Sydney venues where patrons had then gone on to visit and who tested positive to the virus. And so this included a gym, aged care centre, a shopping centre and another hotel. And all of these patrons, we used various strategies to identify their attendance at these different locations. So some of the strategies and sources of information to identify close contacts and their locations of where they visited was using QR codes. And so many restaurants, offices and public places now have a registration system where people check in when they arrive at a premises and to basically record their details and time of attendance. There are other places that we can access information to also identify close contacts from public transport, from flights, from taxi and rideshare operators, from workplace rosters, and if all else fails, from public venues, we use the media to list case locations, timing, and venues where cases may have presented. So in New South Wales, as of the 5th of December, there were about 4,421 positive cases of COVID-19. 2,460 were overseas acquired, 90 were from interstate, and 1,871, so just under half, were locally acquired, and with over 3.5 million tests conducted. In Australia, the cumulative total of COVID cases was just under 28,000 over the last 9 months, with each different colour here in this figure representing cases presenting in different states. So the black shaded area are the cases in New South Wales, and you can see that after the initial peak in the first wave in March, our number of cases have been fairly steady over time. Whereas the blue bars highlight the Victorian situation where they had a bit of an outbreak between July and September, but thankfully and magnificently, they've gotten under control and it's been fairly steady for the last month or so. So I guess what I wanted to do is talk to you about the overall this collaboration, the opportunity of academics working in with the New South Wales Ministry of Health, that basically what it's been is such a positive and rich and rewarding experience working in this team. And it's helped me to appreciate the strengths of the health system and appreciate and understand the health system, and that some of these elements that have contributed to the success and low numbers in New South Wales. And essentially this has really been attributed to the decentralisation of public health units and the large resourcing of the management of COVID-19 across multiple agencies across the state. And the other thing, that most of all the success of the control of COVID across New South Wales has also been attributed to Jenny Musto and the team, what they've called disease detectives and the operations team, in terms of, managing and the outbreak response, and having such the expertise from people from a wide range of disciplines in this operations team that have led to better resourcing, integration and accountability of the health system, which has been able to really respond to the pandemic and the crisis. And various commentators have actually really made positive comments about and compliments about the operations teams, including the Prime Minister, and essentially who's labelled New South Wales as a gold standard, and to ensure the rest of the country basically replicate this this team and the processes to ensure disease control across the country. So this has made me incredibly proud and privileged to be part of the team and had the opportunity with from our university to work with the Ministry of Health. And this partnership has really enabled us to contribute to the management of COVID-19 pandemic across the state. So I'd just like to finish by acknowledging the Ministry of Health and the Public Health Response Branch and the various team members and the university for providing me the opportunity and the secondment to go over and work with the team. Thank you.
Thank you very much, Natasha. And I think it's clear that what you have outlined, very systematic communications, not just to the public, but also to the officials and managers who are directly in the front line of controlling the outbreak. I think there's often the view that communication is just to the public, but actually during a crisis, the systematic and transparent communication to the operations team, like what you have outlined, including healthcare workers, can go a long way towards managing anxiety, restoring confidence. So with that, thanks again, Natasha. I would like to move on to Professor Alex Cook from the Salisbury Hawk School of Public Health at the National University of Singapore, where he'll be talking about some of the models that have been co-created by academia and government during the COVID-19 outbreak. So over to you, Alex.
Okay, thank you very much, boss. So it's a great honor to be able to present at this esteemed forum some of the work that we're doing within the School of Public Health at the National University of Singapore to contribute to Singapore's response. I'll be talking very specifically about the modeling contributions, but actually across all the different domains of expertise within the school, I think pretty much everyone has been working very hard in 2020. Now, because I think not everyone in the audience will be as familiar with Singapore's epidemiology for COVID as they are with the other big countries like China, Australia, and America. I'm going to spend the very first part of the talk talking about the idiosyncrasies of Singapore's epidemic to date. And then I shall talk a little bit about the policies which have been implemented in order to set the scene for me to talk about the modeling which helped to inform the decision-making about those policies. So I'll move on to the next slide. So on discovering that we're part of APRU, I looked around to see which other countries were in it, and I pulled out the COVID case data for all the different APRU countries. And you can see that there's quite a clear distinction between countries on the Western Pacific in blue and then countries in the Eastern Pacific in orange in terms of the severity of the epidemic so far. I want to highlight two countries for comparison. First, USA, which I think everyone knows is having a pretty bad time at the present. And then I'm going to highlight Singapore. So Singapore is an outlier amongst the Western Pacific countries in terms of the number of cases that we have had. Up until June, actually the epidemic curves for Singapore and the US followed each other very closely. And it's only really been in the second half of 2020 that Singapore started to diverge away from that trajectory and towards something a little bit more like the other Western Pacific countries. But of course, we know that the diagnosed cases is not the entire picture. Only a subset of infections will be diagnosed, and that is a reflection of a bunch of other things such as health-seeking behavior, testing capabilities, and the aggressiveness of the test and treat program that we've got in place. So I think it's also important to look at severity as a measure of the outcome. So I'm going to show the same chart, but where I'm showing the number of deaths as a per mil of the population. Again, I'm going to highlight separately West and East Pacific. We can see quite a big difference in terms of the overall numbers of deaths. Some of the worst affected countries so far from the east side of the Pacific are close to around about 1 in 1,000 of the population having died so far. Now I'm going to highlight again the US and Singapore. US all the way up at the top. In contrast to the previous chart, Singapore is at the bottom. So it's just behind China and Thailand, so the top performing countries, and just ahead of New Zealand. So what is behind this Singapore being such an outlier in terms of the diagnosed case fatality rate? So I think to look at this, we're going to dive a little bit deeper into the epidemiology of the pandemic within the Singapore's borders. So I'm showing you here the timeline up until the start of December in the number of cases that we've seen. We went into a lockdown in early April that lasted for 2 months. We called it the circuit breaker because it was meant to be a mild form of lockdown. But during that lockdown period, you can see that there was a surge in the number of infections. We reached around about 1,000 infections a day in a population of 5 to 6 million. Good luck to anyone who's trying to meta-analyze the impact of lockdowns, given that in Singapore's case, it seemed to exacerbate the situation. However, this curve does not tell the entire story. And I think it's important to realize that actually there were these almost like 3 concurrent but semi-independent epidemics that were ongoing over 2020 within Singapore. In orange, I'm showing the imported numbers of cases. In blue, I'm showing those in the general community. And then in black is the huge outbreak that we've experienced amongst our foreign worker population. To date, something like 90 to 95% of all of the infections that we have experienced have been in that very select group. Let's zoom in on them a little bit. So Singapore has a population of around about 300,000 men, mostly from Bangladesh, China, India, Myanmar, who work in things like construction and marine industry, etc. They're quite low income, and they will, to save money, stay in dormitories like this. The dormitories that our foreign workers live in will often have 10 to 20 men sharing a bedroom and bunk beds, not well spaced out. And so when Singapore went into lockdown for those 2 months, while the rest of the population was able to use that to socially distance from others and therefore reduce infection pressure, for our foreign worker population, if they go into lockdown for 2 months, then they're not going to socially distance. They're going to be even more in close proximity to each other. And this led to clinical attack rates of around about a quarter of our foreign workers got COVID. And from some of the serological studies, and we've got a paper that will appear in JAMA quite soon on this, it seems like for many of the dorms, most of the workers actually got infected, and we may actually have reached herd immunity in many dorms. Now, what makes it really lucky from Singapore's perspective is that these foreign workers are mostly young and fairly healthy men, and therefore the risk of getting severe infections was relatively low. So we had very low ICU utilization from them and almost no deaths. So a single man died out of around about 100,000 men who got infected or more. So because the epidemiology amongst this group is so different from the rest of the population, and the measures for control are also very different. Basically, we need to build better housing. So I'm going to be moving them out from discussion going forward and focusing on the resident population, for whom the kind of policies that have been implemented elsewhere can have a bit more of an impact. So if we zoom in then on just everyone else apart from those 90% who are foreign workers, we can see that actually the situation in Singapore has been really mild for almost the whole of the year. In the general community, since around about August, there have been almost no infections. All of the cases that we're seeing now pretty much are imported from other countries. Also, it suggests that circuit breaker does have an impact in reducing the amount of transmission in those who are able to socially distance at home. So what are some of the policies that have been put in place in order to achieve the relatively good outcomes that we've seen in the general population? I'm going to go through some of those. I think that they're quite similar to what we've seen from both China and Australia's situation. So the period of lockdown, quite similar. Schools, workplaces, shops were mostly closed. Most work stopped or moved to working at home, although essential work continued, such as being a mathematical modeler, that was allowed to continue. Restaurants were able to continue giving like takeaways, etc. I'm showing this picture on the outside of a mall because you can see the chairs outside that look like little snakes have half of the spaces blocked off by X's. So throughout the whole of the year, we've been imposing social distancing measures in order to prevent strangers from getting too close to each other and thereby reduce transmission risk. Another measure which has been quite widely adopted is mask wearing. So it is near universal in most situations outside the home. Masks have been provided to the resident population. Here you can see a guy somehow using his phone to get a mask from a vending machine for free. I don't know how that works, but mask use has been one of the key drivers for preventing transmission to others in Singapore. Now, similar to the Australian case, we have a very strong contact tracing team in Singapore. This mostly involves manual contact tracing. So for example, a contact tracer will spend about a day interviewing a case and their contacts and getting contacts to be quarantined at home. But this is supplemented by two forms of electronic contact tracing. So one is safe entry. So outside malls like this one, as well as shops, restaurants, offices, schools, etc. People will scan a QR code and register their details just in case they get infected, and we can use that to try to identify who they might have exposed. And then since the very beginning of the year, I think Singapore was one of the first countries to develop an app which could be used to detect proximity. Now around about 60% of the population has either the app or a standalone dongle, which will help to identify the kind of casual contacts that may not be recalled, and therefore widen the potential set of exposed individuals who can be quarantined. So I mentioned their quarantine. So Singapore has taken a very serious approach to isolation and quarantine of cases and the contacts. So in Singapore, all cases are isolated. There's no such thing as home isolation in Singapore. All cases will be preferentially put into a hospital until they recover, or failing that, into something that's similar to China's Fangchang hospitals that Dr. Huang mentioned earlier. So temporary facilities in which patients can recover from infection without exposing their family members to any risk. So contacts such as family members or people that they came into contact with at work will be put onto quarantine for 2 weeks. And that is heavily monitored by daily phone calls to MOH to check that they're really still at their home. If you violate the quarantine, then you will get in trouble with the law. New people arriving into the country are subject to quarantine as well now. This is in hotels. I have a new colleague just recently arrived into Singapore, and he's in the Shangri-La, spending 2 weeks there, enjoying himself before he gets out. Except for the very lowest risk countries, like New Zealand or Brunei, almost all other travelers will be subject to this. And people from Hong Kong, because the bubble burst. Okay. So, so those are the kind of the suite of policies that have been implemented from very early on in the year. Now, how has modeling helped to inform the implementation of those policies? So countries everywhere are supposed to have a pandemic preparedness plan, basically a book of like ideas for what they can do in certain situations in order to prevent a pandemic from spreading. The problem with most of those pandemic preparedness plans is that the things in the plan have not really been tested out until the year 2020, right? So we didn't know what the impact of mass working from home was going to be until this year. And yet policymakers have still got to make decisions about should we encourage this or not. So early on in the pandemic, we were deployed to help develop models which would let us look at some of the policies being considered and evaluate in silico whether they should be used or not. So we developed actually the world's first agent-based model of COVID pandemic, which was published in some of the Lancet journals. And this is a very highly detailed representation of the resident population of Singapore using GIS data, using demographic data from the census, using all sorts of things in order to simulate the population in a very realistic and granular fashion, and then impose on top of that a model of COVID. Now, of course, at the beginning of the year in January, we didn't really know that much about COVID apart from the earliest studies that were coming out of China. So over time, we've been gradually updating the model to include the latest epidemiological findings. So I'm just going to run through some of the examples of this. So we were asked to look at some of the policies being considered. One of the earliest findings that we had was, of course, doing nothing was going to be a really bad idea, but also that just doing quarantine and isolation, or just doing workplace distancing, or just school closure would not be enough to really slow down the epidemic given the high transmissibility, and instead a combination of strategies, as actually ended up being done in Singapore, was necessary in order to buy time to get testing capacity up, to get more idea about how to treat the patients, to build the Fangchang hospitals, etc. We also used the same modeling framework to assess the impact of the isolation that we were implementing versus home isolation, which some other countries have been doing. So this demonstrates, we believe quite clearly, that institutional isolation, i.e. getting people away from their households so that they will not infect the household members, can substantially reduce the amount of infections. And this is supplemented by some of the more recent findings from household studies, both in Singapore, China, and the US, which demonstrates that in America, where I believe that home-based isolation is still implemented, the secondary attack rate is about 3 times higher than it is in China or Singapore. And you don't need to be a mathematical modeler to know that if the infection rate is 3 times higher, that you're not going to be able to control the pandemic if you continue to have home-based isolation. So one of the other things that we were asked to look into was whether we should go into a mass lockdown, similar to what China led the way with in the early outbreak in Wuhan. And if so, when should we do it? Should we do it early? Should we do it late? And how long should we do it for? So we simulated lots of different scenarios. That's a huge number. I'm only showing a small number here. But this suggested that it was important to go in early and, importantly, to have a plan for what you're going to do afterwards. If you relax your measures after the lockdown period, then the epidemic is going to pop back up again unless you've got other measures in place in order to reduce transmissibility. So after we exited Singapore's lockdown, we went into a series of phases in which we gradually lowered the intensity of our control policies. We're now in phase 2, looking forward, this is 6 months later, looking forward to going to phase 3, hopefully at the end of this month. Okay. So that was the first case study. That was early on in the pandemic when information was scant and we were wondering about how much we should close things down. Now we're in a situation where we're trying to work out how we can safely open things up. And so we've been thinking about how to make international travel into and out of Singapore safer so that we can avoid having those 14 days of quarantine. Note the conflict of interest declaration there. So we've been taking a model which we've now published in Journal of Travel Medicine, where we simulate large numbers of passengers coming into the country and exposing them to different forms of the border fence, and then trying to work out from there how many people would be able to bypass the border fence without being detected. I'll just very quickly run through how we do this. So we built it so that we can look at a large point prevalence in the source country, and then therefore we can apply the policies, same basket of policies, but to different source countries, and use that to try to assess how strict we need to be for different places. So for example, the higher prevalence countries like the US, we may need to have a stricter form of quarantine than for the low prevalence countries like Thailand, for instance. So in the charts I'm going to be showing you here, we'll have the number at the bottom and the percentage of the cases that breach the border fence, and then under different scenarios, such as a pre-trip PCR test, which we think would knock off about 70% of the infections because they'd be identified before they travel. A further 15% would be knocked off by having an on-arrival antigen test. And then various lengths of quarantine with testing throughout the quarantine, let's say a frequency of every 2 days, for instance, can reduce the number of missed infections down to much smaller numbers, which may be more tolerable to the policymaker. We do this for a large number of different point prevalence in the source country, and we can use this based on a risk budget, which our government colleagues can let us know about, to identify which would then be the least burdensome form of control that stays within that risk budget. So if the risk budget is 5 infections getting through per 10,000 travelers, then the set of non-blacked out policies would be the ones that should be acceptable under that strategy. So in developing these models, we've been working very closely with the government throughout, and in fact, some of the papers are co-authored with colleagues from MOH. We've reached several lessons about how we can try to effectively co-create the models with them. I think that one of the most important one is that we make sure that we are answering real problems and not purely academic problems, which of course is something that a lot of academics like to do. Yeah, you may get a publication out of it, but if it's not addressing something that's genuine, then it's not going to get you, it's not going to get you out of lockdown soon. Important to be accessible and to be useful. I still recall a time when one of my buddies in MOH calls me at 7:45 in the morning to say, I need some help with a model. I'm presenting to the minister in 45 minutes. Can you help out with that? Of course, we have to try to help out with that kind of situation. And I think that's what we've seen from both the China and Australia situations is that it's been quite widespread in a lot of the well-functioning responses to the pandemic. The final point is, of course, it's necessary to close the loop at both sides. So from the academics' perspective, once we have the results or a preliminary set of results, we got to show them straight away. We don't wait until the whole publication process happens. And 6 months later, we send them a PDF of the journal article. But similarly, from the government perspective, they need to let us know when the policies are being used or when policies have actually been informed by the modeling that we have implemented. So it would be remiss of me not to thank the people who actually did the work, which is my team there, as well as the people who funded the work, which is NMRC, SPHERIC, and National University of Singapore. Thank you very much for your attention.
Thanks very much, Alex. And I think what you have highlighted clearly shows that in Singapore, the government works closely with the scientists to make use of information, evidence that's emerging to design some of the control and management policies. And I suspect it's worth highlighting that in Singapore, when local scientists established that asymptomatic transmission has happened, not just a possibility, and they were able to do this because of the very thorough contact tracing that happens in the country, actually a lot of local policies changed, including a rather overnight change in the policy on mask wearing. And I think Alex also highlighted the bit about how all cases that are found to be PCR positive are isolated away from the family and the community to avoid seeding further transmission. So thanks very much, Alex. And I would like to move on to our fourth speaker today, Professor Alina Dorian, who is from the Fielding School of Public Health over at UCLA. And she'll be speaking today about the COVID-19 Virtual Training Academy. Over to you, Alina.
Great, thank you. I hope you can see my screen and I hope you can hear me because the entire time it says I have an unstable internet. My luck, right? So hopefully we can, move forward and you're able to hear me throughout the whole presentation. So thank you for having me. Dean YY, can you hear me? I just want to make sure we're okay.
Yes, I can hear you loud and clear. Thank you.
Thank you so much. All right. So my presentation is a little different in that I will be focusing on one major project that we have had in the state of California, which is the COVID-19 Virtual Training Academy. The project was initiated by the governor's office, where they came to UCLA and UCSF, asking us to work with the California Department of Public Health and really looking at how to quickly stand up a workforce to be able to do contact tracing initially and then case investigation as things moved on. It is the largest training academy right now that we have for workforce development in the state. We launched in May 2020 with the goal of training 10,000 contact tracers as part of the state's reopening plan. And it has sort of three parts. One is the virtual training academy itself. The other one is just really looking at building a public health workforce to be able to do contact tracing for the state. And then the data platforms and what that looks like for us to be able to coordinate the state of California. So just really quickly, and I'm counties and 3 city health departments, all of which have their own county health officer and all those orders that come from each one of those counties and making really that kind of decision. While we have the state's orders are considered minimum standards, and each county can basically enact even stricter regulations if they would like. So when we started the Virtual Training Academy, it's a 4-day training, which is really long if you look at all of the other training academies that have happened, at least in the United States. It's very comprehensive in the way we do the training. And we really focus, I would say, the sort of the gold standard piece of what we do is our skills lab. It's very interactive. It's not just about building knowledge, but it's truly about ability, but really, really importantly, building confidence in being able to actually do public health, right? To be able to do these things. There's a large team, right? So we have UCLA, UCSF, CDPH, the California Department of Public Health. And then we have all of these groups that we've sort of broken out into. We have training specialists, we have adult pedagogy specialists and community looking at continuing higher education. education, experienced CIs, case investigators, and CTs, contact tracers, and then really thinking about how this is delivered, where it's not just about epidemiology and biology, but it really looks at building, a contextual moment or 40 minutes with the client that you're working with. So really looking at health coaching skills, right? Motivational interviewing skills, building rapport and trust with the client or the person that we're speaking to. Really this holistic model that's very client-centered and very much of an advocacy model. So looking at the case investigator and the contact tracer as an advocate for the case or the contact to ensure that they're able to isolate or quarantine and have those wraparound services. Another thing that we really needed to do was think about our own workforce. To be able to do this, we had a lot of people that we needed to bring on really quickly and thinking about their own training, but also their own health and welfare. So we have all of these committees that we were divided into the task forces. For example, the curriculum task force that really looked at developing, finalizing the virtual training academy presentations, practice labs, and other offshoots, which I'll talk about. So this has led to many other kinds of trainings that sort of this platform and infrastructure has allowed us to do. We have the M&E Monitoring and Evaluation Task Force, which really was responsible for knowledge assessment, confidence assessment here, but again, looking at the larger scheme of just training this way and looking at the offshoots that we had in the expansion. We have one called Communities of Practice, where we really look at ongoing and support and training for those that have come through the academy, but what do they need once they go out into the field? And we have things like some of the local health jurisdictions have their supervisors that we do a community of practice with, weekly, basically meeting with them. We have regional local health jurisdictions or local health departments that come together and we run those kinds of both technical meetings, but also really looking at the welfare and well-being of our contact tracers and case investigators. And then, as I mentioned, for our own workforce as well. So when we started this, it was really unsure who the learner was going to be. Like, where were we going to get this workforce from? And the idea was that we were going to train state, tribal nation, or city, county, government redirected staff. So the governor basically stated that 5% of all government staff in any agency needed to be redirected, some on a volunteer basis, some on a voluntold basis, to be able to come through and start building up this workforce of contact tracing and case investigation for all of the local health jurisdictions throughout the state. So again, as I mentioned, that's 58 county health departments, 3 city, and then we have one that just has an environmental health department as well. So really, how do we train this redirected staff? Who are they? So we had librarian, parks and recreation, tax assessors, correctional facilities, all of those state departments that really were not considered essential services and that they could give us 5% of their staff so that we can put them through the training and redirect them into the public health workforce. So this is the general overview of the VTA. It consisted originally, really our focus was contact tracing. We really started there and started bringing people into the contact tracing track. But we realized very quickly as we started pivoting that we thought originally we didn't have enough contact tracers, had enough case investigators, and come to find out we don't have enough case investigators. So we pivoted, added that track as we moved forward in really building up case investigators. And then we added a third track, which was case investigators, so contact tracers that would come back as VTA alumni, we called them, and be retrained as case investigators and then be redeployed out to the local health jurisdiction. So over the 4 days, as I talked about, they come in, there's a pre-training assessment, which I'll talk a little bit more about, just looking at knowledge and sort of confidence levels of skills. And then we have about 10 hours of live webinars, about 4 hours of some self-study activities that they need to do, and then an additional 3 to 9 hours of skills labs, depending on which track that they were in. Following their training, they do a post-training assessment. And then following that, post, after they are actually deployed, we followed up and did another assessment to see how well they felt about the skills that they had earned and gained, but also what do they need, right? I keep talking about, this idea of we're on a Corona coaster and it's constantly shifting. And we need to be just as agile in all of the work that we're doing and shifting with all of that. We also, by the way, were able to give continuing education credits for any of our clinical staff that came through. So it's a 4-day, as I said, and as we were doing it, we realized, we might need an orientation day, day 0, because a lot of the learners that we had coming through had a hard time with our learning management system. They weren't used to doing that. A lot of their emails wouldn't work, like state staff couldn't get on Gmail or Google or whatever it was. And so really figuring out some of those issues that we had, we decided to have an orientation day, which is voluntary. Whoever wants comes in. We talk about some of the objectives in general explanation of the learning management system, and get them registered. And then we walk in on the first day. We really do overview of COVID-19, role of contact tracing, introduction to the scripts, interview scripts. So we use general scripts, which, by the way, all of them then go out into the county health departments and utilize their scripts. All county health departments have their own scripts. So we train them on sort of the basic skills of the general script, and then they do some of that other learning that once they go out into that into each county. And then we do a lot of what I call sort of the soft skills, which are actually the thrive skills in being able to do this, right? Really thinking about motivational interviewing skills, health coaching skills, respecting context. What does that look like? How do we do these things? And what we expect from them in the real world comes out in day 3. So we have a panel where we bring contact tracers and case investigators in. It really kind of sets the stage because so many of them, again, remember, these are librarians, tax assessors that have come in. They don't even really know the public health workforce and what that looks like. And that was one of the things that, we learned early on, that we take for granted what we do in public health, thinking, as we're building capacity, that most of these people also understand social determinants of health, why we collect demographic information, and that wasn't true. So really spending some time so our learners understood just public health in general, but also so they were able to feel confident in explaining this to the case that they had in front of them or the contact that they had in front of them. And then day 4 also has the CalConnect database, which I'll talk a little bit about. That was actually created by the state for COVID-19 contact tracing for all of the counties, but it was voluntary. So whichever county wanted to sign up for CalConnect actually would go on it. And then we had additional skills labs, which ended up being very well attended, where people realized we need a little bit more practice before we go out and actually do the work. So our skills labs are really, I think, the unique, kind of the secret sauce of what we've been doing. And they allow us in smaller groups to really start pushing a little bit beyond people's comfort zones, right? Really looking at adult pedagogy where they need to actually do it and practice it to be able to feel that they have that skill as they're moving forward. So we created kind of these safe spaces, or I like to call them brave spaces, where we would take the theory and then break them into these 250-person learner skills labs, which are broken into even smaller breakout rooms of 5 to 7 learners in each breakout room with one facilitator. So you could see how workforce heavy in many ways the Virtual Training Academy was. And that's one of the things where originally we had a lot of local health jurisdictions that wanted to do, their own training. They have their training units within their local health departments. And they started realizing that just an online training, being able to run these skills labs takes a lot of work and effort and good facilitators to be able to truly build the skills. So they started, but most of them kind of came back through the VTA afterwards. So as I said, we have the learning management system, Canvas, that's run through UCLA Extension. So our extension program at UCLA is very hardy in bringing in learners from across the globe and being able to house a really good learning management system. We had a few issues in the beginning because, again, those that are not regularly students or regularly utilizing this, it takes a little bit of know-how. It's user-friendly, but still knowing where to go. But it allowed us a really robust place to be able to have them complete and submit homework, review course agendas, store the webinars that were recorded, have their a place for them to download their facilitator packets as well as their learner packets, and just really have a place to have house everything. And we allow all of the alumni to have access back to their their course sites for 4 months following once they're done with it. But we also go back in and help refresh. So if there's changes that are made, we'll upload the newest presentations for them as well. And we all know how many changes constantly happen in such a big, in our systems. So the other thing we have is this CalConnect platform. Basically, all local health jurisdictions, again, all 58 of those county ones, have to report to the state. And so what the state tried to do was create this database that kind of overlaid on the system that they had to utilize anyway, and created this platform, CalConnect. About 34 local health jurisdictions at this point have actually signed on and are utilizing CalConnect. And our training is optional on that, as I talked about on Friday. And now, when I said, we have all these offshoots, one of the main places we have an offshoot is in schools. So really, we've been pivoting a lot to really thinking about school training and school reopening. So CalConnect has also added a new thing called Spot, which is the school portal for local health jurisdictions, but it also allows school administrators to actually log in their cases that way, and sort of it comes directly there. Their line lists actually are connected directly to the county that is using it. So again, positive case, it's reported, triggers CalConnect, CalConnect then starts their case investigation and contact tracing through each of those health departments. Now, I said 34 have it. So the rest, we still have to figure out, how does their database work? How do we utilize that? How do we collect this information and collate it at the state level as well? So to date, we have had more than 10,000 learners come through. So we've hit our initial goal, but the total enrolled here that I've given you is the actual 23 cohorts that we've had that don't count the pilots. So we had 2 pilots where we had, more learners going through, but in our last 23 cohorts, we've trained 9,900 people. We have an 86% completion rate, but completion doesn't mean they didn't complete training. Basically, in order for us to consider somebody completed, they also have to have turned in all of the homework assignments. They had to have done the pre-test, post-test. They have to, sort of all of those T's had to be crossed, I's had to be dotted in order for us to keep it at completion. The other thing is we have a lot of people that are still doing other jobs, right? And so as they're doing that, they may drop out, come back, and then hop back in day 3 in a new cohort as they're going through. So really looking at that as we move forward. As I stated, we really started with contact tracing. So you see the yellow. These are the number that we had per week coming through. We then built out the blue with the case investigation. And then as you see, once we started hitting, sort of July, mostly end of June, July, really CI started becoming the main point of our training activities. And coming soon in December, we're actually, in the end of December, we're thinking of actually just stopping the CT tract altogether, kind of incorporating it into the CI and just making sure everybody has a CI-CT information and is trained on that moving forward. The numbers actually, when they started decreasing, was the same time where we started doing more training on outbreak management specialists. So local health jurisdictions started at that point pivoting with the workforce that they had and started thinking about how do we create enough of a team to be able to do outbreak management. And now they're also pivoting, how do we create a team to help with schools? So we have sort of school specialists that we're starting to train that can work with through local health jurisdictions with the schools and the districts. So our participants, when you look at the sort of educational attainment, we have everything from high school to graduate clinical education. And why this is just kind of important is because initially when we started, there was this idea that what do you actually need? What degree do you actually need to be a contact tracer or a case investigator? And we started realizing that the best contact tracers and case investigators that we have are not necessarily built on their educational attainment. It really comes back to those other skills. Somebody who feels comfortable and has that skill of health coaching, right? Is detail-oriented, client-centered, empathetic, right? Culturally sensitive, understands context, because coming back to some of the things Alex talked about with our extreme, which I was gonna ignore, but our extreme shooting up in the United States, a lot of it comes down to, people and their understanding of the health messaging and our inconsistencies in trying to really change behavior and what that looks like. And so we realized that at least through our contact tracing case investigation, it's not just about the epi and the tracking, it's about empowering the individual that we're talking to be able to make those changes in behavior, which we know are one of the hardest things to do. And also you need somebody who's super flexible, has a sense of humor, because again, I said we're on that Corona coaster and things change all the time, but also resourceful, right? So every time you have a client in front of you, yes, we know what each county can provide, where we can send people, but sometimes there are questions that need to be answered, and you need somebody that feels confident in sort of navigating that system and being able to find the answer for the person on the phone. The most interesting thing in all of this was the idea that we know 70% of our case investigators and contact tracers had no public health related background at all in their job or what they did. And I think this was really important because initially, again, we weren't sure what that was going to look like when we brought them in, and didn't realize that we needed to do a lot of work in the front end on what is public health. And for many of you that have ever tried to explain public health, it's not as easy as it sounds, right? And so really trying to help them have a context of where they're working, but also really we take for granted, again, that I was talking about, why do we collect some of this demographic information? What does disparities mean? What do social determinants mean? How are we constructing all of this? And just sort of trying to give them a quick public 101 as they're moving forward, since they're representing the local health jurisdictions as they're moving forward, I think was important. And again, just being able to truly have those skills to be able to speak to the client was important. So local health jurisdictions, there was 2 ways that we actually got learners coming into the system. One was local health jurisdictions sending staff. So for example, the counties would work with their county offices, city offices, and redirect staff that was going to be in the local health jurisdiction. They would send them through the virtual training academy. And then the second line was, as I talked about, really the state. So the state redirected staff through state agencies, they came through there, and then they were then seconded to some of the different local health jurisdictions after they finished the training. So 92% of local health jurisdictions enrolled at least one learner through the VTA, and 5 local health jurisdictions enrolled none, but those are very small local health jurisdictions, basically. And state staff were actually redirected to a lot of them to help with any of the the hired cases when they had. And then 13 local health jurisdictions enrolled more than 100 people directly from their own staff into the virtual training academy. So as I said, 56 of the 61 had somebody from the local health jurisdiction actually come through the virtual training academy. These are the 13 bigger counties that sent their employees through to be trained. The percentages on there are the completion rates of each of those counties. But again, I think it's important to note, so for example, if you look at LA County, where I also, by the way, I'm a public health commissioner, so I work very closely with LA County. You can see based on this, there's about 200 staff that LA County sent from their actual redirected staff into a local health jurisdiction, but the state sent about 1,200 to 1,500, depending on the time that we're looking at, state redirected staff to LA County that were trained through the virtual training academy. So just quickly, M&E was really important as we were moving forward. And I said also kind of building a blueprint, because again, we've taken this infrastructure and expanded it to other trainings with the local health jurisdictions throughout the state. But again, before training, we collected the information through registration, looking at education, experience, those demographics. We did a pre-test looking at knowledge and really confidence, a post-test following the training, looking at knowledge and confidence. And then even though it says 2 weeks after training, it really depended on when staff were actually deployed. So we did not do a post-post for those that were not deployed and utilizing their skills within a local health jurisdiction. We waited. And that could have been anywhere between 1 to 3 weeks by the time staff were actually then after training redirected into a local health jurisdiction. But we also did a lot of work with the alumni qualitative, key informant interviews, focus groups, and really thinking about What can we do to adapt to the changes? How do we make changes through this infrastructure that we have in place with VTA, as well as, streamlining and making efficiencies throughout the system of training. So again, knowledge questions, very basic, and just, making sure that pre-post, so the important sort of key indicators were there. We had 15 questions for contact tracers, 17 for case investigators. We had a really good change in knowledge, but also important to note that we had a lot of them had a good sense coming in. So they were voluntold, some of them, but most of them volunteered. So we really look at that as well. And then just changes in self-assessment of the skills, right? So here's confidence levels, looking at a Likert scale out of 5, red being where we don't want to be with 1, 5 being on the blues. Pre, post, you see a huge difference where we're really looking at that royal blue coming through, and changes in confidence, because as a practitioner, I know that confidence and skills is the most important thing in being able to mobilize and at this kind of a workforce. And then in our post, we saw some really great changes as well on the Likert scale. Again, really agreeing that they felt confident, at least when they started doing the work 2 weeks out. Some qualitative just feedback, which really went back to the same things. Confidence, felt ready, practice, prepared. I'm trying to go quickly, Dean YY. I see you on the screen, so I don't know if my time is up, but I'm moving. And then just the whole workforce expansion piece and moving forward. As of August, we had already trained 3,600 state employees that were then, as I said, redirected to 28 local health jurisdictions, which came from 100 state agencies and programs. And I always love it because every time we introduce ourselves in any of these meetings, we always say, and my day job is, right? Remembering that we still have both of those things as we're moving forward in many of these things. And we have VTA 2.0, as I talked about, extension, really moving some of the things that we had done with adding Spanish labs, really some of the alumni refreshers. And I think the biggest thing is really expansion. We started with CTCI, but really moved into outbreak management training for our local health jurisdictions and realizing they needed the teams for correctional facilities, schools, work sites, SNFs, long care facilities, as well as people experiencing homelessness. That's been a really big challenge for us as well. A cultural humility piece was added, working with community-based organizations. And I think right now the biggest issue that we've all pivoted to for us is really schools. So we're creating a school specialist for local health jurisdictions where they can work with the schools, liaise with the schools. But we just started a new collaboration with UCLA School of Education, where we're actually training school administrators and school sites to be able to understand what public health is actually telling them, because sometimes we speak different languages and it doesn't work. So taking our guidance and saying what actually makes sense in a school setting and how do we actually go about doing that. So I think this is my last slide. I mean, these are all the lessons learned. I just want to focus on a few things. Most important, workforce issues, right? The United States especially really has decreased its funding to public health. And that was a really big issue for us right now. I always say, people say to me, Dr. Dorian, now everybody wants to go into public health because of the pandemic and public health is the star. And I say, no, public health was the star the 100 years we didn't have the pandemic, right? And so really thinking about what our role has been and what that looks like as we're moving forward. The other big issue for all of us in the United States and moving forward has been mistrust. We have just really groups that have always been woefully ignored by government and or structural racism. So there's already sort of that layer that we needed to build upon as we moved forward. Misinformation, disinformation, mixed messages, the political messages around the disease and things like mask wearing, et cetera. Partnerships, with agencies, other agencies, that is a disaster 101 is you need to have relationships before a disaster happens. And now we're seeing that issue with schools where our local health jurisdictions didn't have that close connection with schools. And now we're scrambling to build those partnerships to be able to move forward. And I think last but not least, it's the idea that all of this is about behavior change for us, which is already difficult to do, one of the hardest things, and we're trying to do it during a pandemic, right? And thinking about it. And last but not least, I think the biggest thing I've learned is just humility through this process, right? No ego, really understanding that you need to pivot when you need to pivot. As we're riding this Corona coaster, every day we're learning something new. What do we need to do to ensure that we're doing the best that we can for the population that we are there to serve. So I believe that is my last slide. Thank you very much.
Thanks very much, Alina. So I think what you've highlighted is actually something very important to public health academics, that we do have an important mandate that goes beyond the research, the teaching, the publishing that we do as a typical academic, but we have a practice and an implementation mandate where part of this mandate is to teach others. It could be public, it could be people who have a keen interest in public health, skill sets that will be relevant in a crisis. And in this particular crisis, skill sets such as infection prevention and control, outbreak management, contact tracing that you have highlighted. But I think that this aspect on public health academics, on implementation, on practice, is something that is often overlooked by universities, especially when they're starting to think about appraising performance, including for promotion, for tenure. We have a social and professional responsibility that goes beyond just the typical academic mission. And I think that universities need to reorientate some of their internal protocols to recognize and respect this practice mandate that we have rather uniquely. Now, I realize that we have only about 5 to 7 minutes left for question and answer. We have received a few questions, but what I will do is very much focus on, I suspect, just 1 or 2 questions that are most pertinent. And I think I will go back to Natasha at this point in time. Natasha, and you have outlined a very well-organized setup that New South Wales has, particularly from the operations, the public health units that you talk about. And I think this speaks very well for the overall management of the outbreak locally. And I think the question I wanted to ask is a little bit more forward-looking, because as we look to the future where vaccines are going to be delivered to the population, how is this setup that you have in New South Wales, that you're part of, planning to address some of the challenges around vaccine hesitancy to try and encourage more people to come forward to take the vaccines? Specifically, are the academics in your faculty or across the whole country coming forward to work with local federal policymakers, mainly to communicate, to educate, and to inform the public on the vaccines? So over to you, Natasha.
That's a big question. Look, fortunately for us at Sydney University, we have one of the leading, I think, not just national, but international academics, Professor Julie Leask, who's a very strong advocate and knowledgeable person about looking at knowledge and communication and increasing awareness of immunisation and vaccine, and particularly addressing vaccine hesitancy. She's actually on the WHO International Advisory Group for tailoring immunisation to various groups. And one of the things that she really highlights about vaccine hesitancy and addressing this is really understanding that people, for many people, they're cautious and they're uncertain about vaccines, and they often want more information. There's a small group who are against vaccines, but she thinks this larger group who are uncertain and maybe just unaware of the full information is to really try and tailor messages and tailor initiatives to address them. And she identifies 3 key strategies. One is to remove structural barriers, to basically make it vaccination clinics flexible, to make it convenient to get vaccinations. 2, to tailor communication strategies to these fence sitters and to these people uncertain, and delivered by trusted peers and community leaders. And 3, to empower health professionals to basically address the community's concerns. And really what the university, by having this expertise, and Julie's and other leading groups, not just at Sydney Uni, but across the country, are really working with government. So the rollout of the vaccine is going to be by the national government. So it's working with government to really address these barriers and to really try and facilitate the rollout of the vaccine across the country and address those people that might be uncertain.
Thanks very much, Natasha. Very helpful. And it's important to see where academics can play a role in all this. And I just have perhaps time for one last question that I would like to pose to Dr. Yang Mu Huang. And it's really around some of the decision-making process that faces many countries. Singapore, we are small, and that's why we have very unique advantages that countries large countries like including Australia, United States, and China, you do have greater challenges. The question that I have for Dr. Huang is that clearly China has executed a very impressive response throughout the pandemic, be it in trying to understand the coronavirus, the range of public health measures that have been implemented, the actual implementation of the public health measures on the ground. But the reality is that for China, the implementation side actually relies on local, provincial, or district governments instead of the central federal government that may set the policies. So I wanted to actually consult you. What is the successful model of partnership that exists in China? Do academics work with their local governments at the district and provincial level to influence, to evaluate the implementation? Or do they try to work and influence the central government to formulate national policies? I suspect the reality is perhaps it's a mixture of both, but in the case of large countries with very many good schools of public health, how does the central government in China decide who to consult and who to listen to? Over to you, Dr. Huang.
Thank you, Professor Wawa. It's actually a very good question, and I might take a little bit more time. So actually, at the very beginning of the pandemic in Wuhan, at that time, the central government participated more, and actually, I can say that the whole country is trying to work together to support Wuhan, from health workers to food supplies to hospital constructions, and we can all see public health workers participated during the process. So at that time, the national's most well-known academia in multiple disciplines around the nation went to Wuhan during the outbreak to understand and study the disease. I think this is also the reason why we could upgrade our prevention and control protocols, and as well as the diagnostic and treatment protocols within days during the first 2 months. So, and all these experiences have been widely summarized and learned after the first curve in Wuhan, and then the local governments have been asked to be prepared for reemergence, where then we can see local universities and academias, including local CDCs and governments working together, such as providing health educations and doing all those preparedness. So we can see that it's a multilateral collaborations, and academias in different countries, in different universities, actually we work together. So you can see a lot of research proposals are brought up by multiple universities. So we exchange ideas, exchange experiences. So of course, after our first curve in Wuhan, we are still facing reemergence of COVID in different provinces now. So we're trying to manage based on the previous knowledge we have gained. So every time when there is a reemergence in a province or a city, of course, local government act first and take actions immediately based on their protocols they have been prepared during this window time. And beside the local academias, a national well-experienced team formed by China CDC and national health commissions, as well as some well-experienced academias, they will go to the spot and work together with the local government, local academia, and then probably for half of a month or 1 month, and make sure that they have provide all the experiences, and then they will leave this local city and then leave the rest to the local academias and local government. So that is why we always say that domestic collaboration, multilateral collaborations, and collaborations between between universities are super important during this COVID time. Thank you very much.
Thank you very much. And I think this is a very right note to strike as we move towards the conclusion of this session. And I think what I've taken from some of the presentations by our speakers are the following 4 points: that the ability and inability for countries and societies to respond during a crisis actually depends crucially on some of the decisions that have been taken in the past prior to the crisis happening. Because the reality is that academic government collaborations, the trust, the partnerships, they cannot be left to chance, and this needs to be nurtured during peacetime for a working model to be developed or to build trust. So that when the crisis does happen, there are all these networks and trust that can be relied upon to tap on for rapid and quick response. The second is really to highlight that, just as Alina has highlighted the role of the university in playing in knowledge creation and transfer, there is also the importance that have been highlighted by Alex, Natasha, and Yamu around the importance of knowledge implementation as well. How do we make use of the knowledge that academics have produced to guide the development of policies and programs? The third point is really around how universities must increasingly look into their internal frameworks to decide whether they view the role in creating and transferring knowledge to be their sole mission, or whether there is really an element of implementing knowledge and trying to guide the development of evidence-based, sound public policies and programs, both nationally and internationally. And I think the fourth point is really that COVID-19 has been a very valuable learning opportunity to illustrate whether the partnerships between academics, between scientists and policymakers actually exist in a practical sense that has a real impact when it counts. There will be future crises ahead, including climate change, looking at antimicrobial resistance. This will be similarly global. It will similarly impact millions or billions of people. What is our role as academics in this narrative in global crisis? I see that universities must come forward to play the roles that we can, and also to ask how the knowledge that we create or we have actually help to make the world a little bit better and a little bit safer. So with that, we are exactly on the hour. I would like to take this opportunity to thank all the speakers for their very helpful contributions, very insightful points that have been made, as well as APRU for generously hosting this session. Before I end off, I would just like to highlight that there will be the next webinar hosted by APRU together with Peking University, and this will take place on the 13th of January. And the theme for that webinar will be on the promises and challenges of solutions for COVID-19 control. So with that, thank you very much for spending these 2 hours, whether it is in the morning, afternoon, or evening, wherever you are. Thank you again, and I hope this has been a useful, insightful session. Thank you and have a good day ahead. Goodbye, everyone.